Thank you for your introduction and for the invitation. I will present on ventriculomegaly. Ventriculomegaly is a condition when the lateral ventricles are enlarged. It is found in about 1% of fetuses at 20 weeks, making the most common abnormal fetal finding of the brain. When measuring the lateral ventricle, we use an axial view of the brain by visualizing posterior horn and place the calipers at the level of parieto-occipital fissure perpendicular to the ventricular cavity, which is demonstrated from 20 weeks of gestation. Importantly, ventriculomegaly is not a diagnosis itself, but rather a sensitive marker of an underlying pathology, and ventriculomegaly is associated with a wide range of intra- and extracranial anomalies. It is important to systematically evaluate not only both lateral ventricles, but also the anterior complex of the brain, temporal horns, ventricular wall, and periventricular area, as well as cortex of the brain. The severity of ventriculomegaly depends on the measurement, and it can vary from mild, measuring between 10 to 15 millimeters, and severe when the lateral ventricle is more than 15 millimeters. This classification has significant prognostic implications. Fetuses with normal ventricles have a low risk of cerebral anomalies, while those with mild ventriculomegaly are usually normal at birth, however have an increased risk of abnormal outcome. In contrast, CV ventriculomegaly is highly associated with underlying cerebral or non-cerebral cause and abnormal outcome. The ventricular system of the brain is made up of 4 ventricles, 2 lateral ventricles, 1 in each hemisphere, the 3rd ventricle in the diencephalon, and the 4th ventricle in the hindbrain, which is continuous with the spinal cord. Cerebrospinal fluid is formed in the choroid plexus, which is located in all 4 ventricles of the brain. Now, severe isolated ventriculomegaly is typically caused by an obstruction along the normal cerebrospinal fluid pathway, usually at the level of aqueduct. Stenosis of the aqueduct can be congenital due to the congenital narrowing, septum, or periaqueductal cleosis, or acquired stenosis, which can be caused by cerebral hemorrhage, brain injury, inflammation, cyst, or tumor. However, in cases where obstruction is not obvious, our knowledge about the pathogenesis of congenital ventriculomegaly remains incomplete. To understand the cause of ventriculomegaly and determine whether it's isolated or associated with other abnormalities, we must perform a dedicated systematic assessment of the brain, so-called neurosonography, and assessment of the fetal anatomy, with MRI being a valuable tool in cases where ultrasound visualization is limited. Maternal serum testing for cytomegalovirus and toxoplasmosis should be considered. Additionally, genetic testing is important, as ventriculomegaly can indicate an underlying genetic condition. In cases of ventriculomegaly or any other suspected brain abnormality, the axial evaluation of the brain might be not sufficient. This is a very clear example where, from the axial view, a major brain abnormality could be missed. While looking at the same brain from the coronal view, you can see a major brain injury, which is a hemorrhage in this case. Therefore, a systematic assessment of the brain from axial, sagittal, and coronal views should be performed. Transvaginal approach is more informative than transabdominal. However, in many cases, even transabdominal, but systematic evaluation of the brain will be very informative. In cases of ventriculomegaly, irrespective of the severity, a systematic approach of fetal brain assessment should be used. By assessing anatomy of the midline structures, we can exclude septo-optic dysplasia and the genesis of corpus callosum. By assessing infratentorial anatomy or posterior fossa, we can exclude conditions such as cerebellar hypoplasia or so-called Andy-Walker malformation. By assessing parenchyma, we can exclude hemorrhage or infection, and by assessing the cortex, we rule out lissencephaly and other migrational disorders. The most common fetal brain abnormality is callosal pathology. In this case, a complete agenesis of corpus callosum, commonly presenting with ventriculomegaly and absent cavum septum pellucidum. In the first picture, you can see a clear non-visualization of CSP and tear drop shape lateral ventricles. In the coronal view, classic presentation of the anterior complex with displaced and distal anterior horns, and in the sagittal view, direct non-visualization of corpus callosum. Ventriculomegaly can also be a sign of a congenital infection, as in this case, a severe case of toxoplasmosis at 28 weeks, presenting with severe ventriculomegaly, hypoechogenic walls of the lateral ventricles, and multiple cystic changes of the parenchyma of the brain, and toxoplasmosis was confirmed. Or, as in this case, cytomegalovirus destructing fetal brain, presenting with microcephaly and microencephaly, calcifications and ventriculomegaly, and severe cortical malformation of the brain. Ventriculomegaly can also be a sign of disruptive process of the brain or a hemorrhage, as in this case presented at 25 weeks, a fetus with severe bilateral ventriculomegaly and huge hemorrhage and the clot disrupting the whole anatomy of the brain. And in the coronal view, the same case, you can see significant hemorrhage of the brain. In this case, fetal alloimmune thrombocytopenia was confirmed. And it's important to remember that screening for anti-HPA antibodies for cases suggestive of intracerebral hemorrhage should be performed, not because this will improve or change prognosis and outcome of the ongoing pregnancy, but it will definitely improve prognosis for the next pregnancies. And ventriculomegaly can also be a sign of abnormal posterior fossa, including a rare condition of cerebellar hypoplasia called rhomboencephalosynapsis, in which the hemispheres of the cerebellum are fused across the midline in the absence of a vermis. Ventriculomegaly can also be a marker of an underlying migrational disorder, as in this case, at 24 weeks, we can see underdeveloped cortex, smooth surface of the hemispheres, and abnormal Sylvian fissure, together with thick and dysplastic corpus callosum. A detailed assessment of the entire fetal anatomy is also very important, including detailed assessment of the fetal skull to rule out major abnormalities such as encephalocele or craniosynostosis, which can present with ventriculomegaly. Face to rule out major facial defects, ears and eyes, a detailed assessment of the heart, and examination of the spine and extremities, as many additional findings can directly navigate you towards the correct diagnosis. In about 30% of ventriculomegaly, there will be additional extracranial findings. It is important to remember that most often extracranial malformations will be present in more severe cases of ventriculomegaly. Now, what about MRI? The value of fetal brain MRI depends on severity of ventriculomegaly. In non-severe isolated cases, additional MRI findings are present in about 5% of cases, while in severe isolated cases, the number goes up to 20%. The most common MRI findings in severe ventriculomegaly include cortical malformations, midline abnormalities, and acquired conditions such as hemorrhage. Another question to answer is, when do we perform brain MRI? We have looked on the data of 400 fetuses with brain abnormalities, including ventriculomegaly, and we found that postnatal MRI confirmed prenatal diagnosis in 74% of cases, proved wrong in 6% of cases, and showed additional diagnostic information in 20% of cases. So the MRI is important, and not only prenatally, but also postnatally. It is also important to remember, even if a detailed assessment of the brain was performed at around 20 weeks of gestation, some brain anomalies can be detected only in late gestation, including progressive ventriculomegaly. At King's College Hospital in London, we reviewed third trimester ultrasound assessment and found that in 76% of cases, ventriculomegaly was diagnosed for the first time at 36 weeks. This finding highlights the importance of 3 ultrasound scans in pregnancy: first trimester, second trimester, and third trimester scan. Now, what about prognosis? Postnatal neurological outcomes directly depend on the presence or absence of additional disorders, the severity of ventriculomegaly, and how it changes during pregnancy. Now, in isolated, mild, stable cases, the prognosis is good, which is similar to the general population, or 10% risk of some degree of developmental delay. And as we discussed already before, in about 70% of cases, there might be associated other cranial or extracranial defects. And in non-isolated and in progressive ventriculomegaly, the prognosis is poor, with more than 50% risk of developmental delay. Studies highlight the importance of genetic evaluations in cases of fetal ventriculomegaly. Based on recent meta-analysis, chromosomal abnormalities and abnormal microarray results are found in about 8 to 11% of ventriculomegaly cases, and this percentage is higher in non-isolated cases or of ventriculomegaly and is more often abnormal in severe cases of ventriculomegaly. There is also growing evidence that the whole exome sequencing has additional value to chromosomal microarray. A large UK-based study that examined fetal structural brain anomalies, including 64 cases of isolated ventriculomegaly, found a diagnostic yield of exome sequencing of approximately 6%. Now, in cases of severe progressive ventriculomegaly, as we have discussed, the prognosis can be very poor. Is there anything we can do to improve the outcome? Several groups tried and applied different techniques, such as ventriculoamniotic shunting, which is an experimental procedure for severe ventriculomegaly. The idea is to put the shunt and reduce the further dilation of the lateral ventricles. The results, however, are not great. Reported fetal death rates after this procedure is about 14%, and the incidence of moderate to severe postnatal neurological impairment ranges from 30 to 80%. These results may be due to the small number of cases, selection bias, or the use of shunts that fail to ensure unidirectional cerebrospinal fluid flow. Another experimental approach is endoscopic third ventriculostomy that also aims to decrease ventricular dilation before birth, potentially improving neurological outcomes. The idea for using this approach instead of ventriculoamniotic shunting is to avoid possible reflux of amniotic fluid to the ventricular system through the shunt, and to allow the cerebrospinal fluid to follow a more physiological pathway until its absorption. However, these interventions are still under investigation and are not yet standard practice. Thank you very much, and I'm happy to take any questions. Thank you.